Hi, everybody. Thank you so much for spending time with me today on this Zoom session of the Virtual Anesthesia Bootcamp. My name is Tina Tran. I'm an anesthesiologist at Johns Hopkins. At Johns Hopkins, we're associated with the critical care department, so we are part of the anesthesia and critical care medicine division. I'm also part of the ophthalmology division because I do a lot of my work in Wilmer. Caroline, did you want me to start over or?
Oh, no, just before you get into the meat of the presentation, just allow for a couple of minutes for everybody to come in.
Oh, sure, no problem. Thank you. And so I enjoy doing a lot of my anesthesia for patients requiring ophthalmic anesthesia, ophthalmic surgery, ambulatory surgery, as well as taking taking call in OB. And I really enjoy medical student and resident education. I was one of the assistant program directors here at Johns Hopkins, and now I've shifted more towards the medical student side. And we have an advisory program for the medical students, and I'm part of that group as well. Thank you to all you guys. You really inspire us to improve, continue to update our practices because we know you'll take the field of anesthesia in upward and onward. We're really proud of everything you guys do and really honored to be a part of this virtual anesthesia boot camp session to interact with you. Today, I'll be discussing perioperative evaluation and choice of anesthetics. My goal is to have some interaction via the chat. So if there's any questions that I pose to you, and if you can quickly answer in the chat box, that would be great. If you have any questions for me, please put them in the questions and answers. I'll try to stop a few minutes early so that if there's anything you'd like to ask about, we can interact that way. Okay. So for my talks, will be a little bit interactive, but also I'll gather information from things that are published as well as real life. I started my anesthesia residency in 2005, graduated in 2008, and have been at Hopkins since then. So a lot of clinical experience along with published data. I got this image in a very cool website. It's called easymedlearning.com. It has a lot of information about different subspecialties, and they have a couple really funny, great diagrams about anesthesia. So when we talk about anesthesia, it's good to remind ourselves, what is it? And when we're talking about it, that we're all on the same page. So it's a loss of sensation in all or part of the body with or without consciousness. It may involve analgesia, amnesia, some paralysis, levels of unconsciousness, and if the patient is under sedation, there might be some anxiolytics involved. So many things that incorporate anesthesia. So why are we giving anesthesia and anesthetics? It's anyone anyone who's screened by some kind of preoperative evaluation, deemed suitable to receive anesthesia, and will go forward with their anesthesia for their surgery. It's necessary when you would require the patient to be comfortable, be safe, sometimes be completely still for some surgeries and procedures. Anesthesia is administered in several different ways: inhalational, IV, local injection and numbing, or regional injections, such as with spinals and epidurals. Anesthetic administration can occur in several different places, including the OR. Some anesthetics will be given in the ER or in the office or surgical centers. And usually it can be performed safely in an area that has the appropriate monitors, as well as a facility that can provide supports to the providers and to the patients if they need. Surgery is really, really stressful. It comes with many different things that provide imbalance. That's to fluids, if you're NPO, electrolyte balances, if you've had any kind of bowel prep. There can be pain in the perioperative phase, nausea after anesthesia, incisions that can hinder movement and the natural feel of moving about. The recovery period, what that will look like. And people are seeing new faces. They're in new places. They're in gowns. They're cold. They're without their immediate family members at their bedside. So surgery in itself, even before making an incision, can be quite stressful. So how do you prepare for the operative stress test that the patient is going to have? What information is most helpful for you to determine that the patient is going to withstand the stress of having surgery and having an operation? If you want to enter in the chat box, like what test or what interaction with the patient would provide you with the most information about how well the patient will do for their surgery. Great. We have someone saying past medical history. I love it. That's always what you should start with, because anything that is on the Epic chart or on any kind of health records might not reflect. Daily activities of living, physical activity, awesome. Medications, meds, the history and physical. I love that you guys are going to the patient, and one of our colleagues is saying stress tests. And there absolutely are times that stress tests are indicated and provide you with information. But I do love that you guys are going to the patient, talking with the patient, examining them, asking about their functional status. So a patient who is independent and who's healthy and active are likely going to do well for the stress of surgery. What if you didn't have that time to fully interview and examine the patient and you need to go into the OR stat? For example, a patient who has a ruptured appendix and surgery is posted at stat, the patient is in the ER but coming straight up to the OR as soon as possible. The surgery needs to go because it's life or limb. If it ruptures, there's possibly life-threatening sepsis. What information would you gather about from the patient as the patient is in the pre-op area, stretcher, rail guards go up, and the patient is being transported to the OR? You want to focus on information that will help you reduce risk versus having the time and the resources for preoperative testing. So if you could ask the patient a few things quickly, what would you ask the patient? Great. Any complications with anesthesias in the past? If the patient's NPO or what their last intake is, their anticoagulation status, if they have any cardiac or pulmonary conditions. Awesome. This is really wonderful. You guys are thinking about this is the information that's going to let me know about the patient's risk right now as I put them to sleep, as I provide anesthesia for them. Any known allergies, perfect. Because you want to get the medications that they get, but you also don't want to introduce a new set of complications. So with the goal of a preoperative evaluation for any emergency surgery, it's to gather the important informations quickly. And you guys did that with your chat box, and do an airway assessment as much as you can. I do this while I'm talking to the patient. It gives me information about the patient's cognitive status, if they have any deficits, slurring of words. I'm seeing how their mandible are, if they're able to open their mouth, their teeth, and their structures, so that I have this information as I'm talking to them doing my airway assessment. If I'm able to have a stethoscope put on their lungs or see any outward injury, that can provide me with information as well, because once you start to give that anesthesia, you're in a state where you might have to move forward, or the patient can possibly go to a state of instability. So knowing this information is very helpful. If there's someone with the patient at that time, try to gather information from that person as well. If not, you can gather it at a later point in time. Great job, guys. You guys are doing excellent in terms of the questions. So what preoperative evaluation is needed for non-urgent surgery? Now you have more time and resources to investigate. What information is helpful to you now that you have this time and these resources? And I recommend that before you order any tests, order any labs, consider why are you ordering it and what will you do with that information? Because anytime a lab or a test is ordered, there's time to wait, time to result, possibly financial implications. So knowing how this information is useful to you will be helpful. So let's say I'm just going to make up a patient, a 40-year-old female for inguinal hernia repair. What information would you need before going in and administering anesthesia? Or would you proceed with surgery? Okay. Let's see, if there's a EKG, if there's any cardiac history to assess any changes from baseline, A1C if diabetic, a type and screen, and a clearance from PCP. Great. These are all really good things to bring up. So an EKG, if a cardiac history, that would depend on what the history is. So really great thought there. Some of the preoperative locations will have rhythm strips, or the patient will be on some kind of EKG monitor. So looking at that would give you helpful information as well. A1C, if the patient is diabetic, great. I'm glad you're thinking long term, because having a finger stick will not give you the big picture view as hemoglobin A1C is. I love it. Type and screen. I would say for this case, if you were predicting that there would be blood loss, or if the patient is starting off with a very low hemoglobin, a type and screen would be appropriate. However, in cases where you're expecting minimal blood loss, not and the patient has a relatively stable hemoglobin, skipping the type and screen is okay. Um, Creatinine clearance, yes, I would say more towards if you suspect that the patient has any renal issues, and then clearance from PCP. That's a great point of discussion. Oftentimes, that will depend on how thorough this PCP is. Some patients will go to a urgent care and say, "I'm doing fine. I have no issues." The person will get a set of vitals and will say cleared for surgery. So while that input is important, knowing where it comes from, how the person was evaluated is also good information. Checking a CBC for hemoglobin and to rule out any infections. Yes, absolutely. That's also very important. And also, I would say, just like you guys did for the emergency patient, talk to the patient. If you have any concerns, you can also call the patient the night before and have a discussion. In general, what you want to know by asking these questions are, what are the risks? Do I need more information? And if I do need this information, how is that going to affect my anesthetic and clinical care? In general, if the patient is getting low risk surgery and they are low risk of medical comorbidities, oftentimes you would proceed with minimal to no further workup. If the patient is high risk and receiving high risk surgery, cardiac, pulmonary, etc., more workup is usually helpful. Oftentimes, and the majority of our patients fall within the gray zones. They're high risk surgery for low risk patients, low risk surgery for high risk patients, and anywhere in between. And oftentimes, a preoperative evaluation will help clarify the patients in this gray zone. So, how do you assess the patient's health status? What do you ask the patient? Specifically, what do you ask in order to determine the ASA physical status classification? And we'll review what that is. And that's usually a language, a numerical language that will provide information and discussion with anesthesiologists that will give a broad overview of how sick the patient is. So what information would you ask the patient to help you determine their overall general health? Great. Climbing stairs, daily activity of function. Great. So that information is helpful regardless of the patient's medical comorbidities. Because if a patient is running marathons, yet they are on dialysis, what I would tend to go towards is they are healthy, they are active. Yes, they are on dialysis, but they are overcoming any of the barriers that potentially come with it. So in addition to asking the medical comorbidities, medications, allergies, move on to ask about the stability of symptoms, the patient's compliance with their recommendations, their activity and functional status, and support from loved ones. Knowing the patient's overall support can help you understand what are the barriers to patient getting access to some of the support, and how you can help them maybe have a post-operative social worker engage with them to help make sure that they continue to recover after discharge. The ASA status is a form of communication to let us know about the patient in general and their health with some of the examples. ASA 1, a healthy, normal patient, is pretty much understood, whereas ASA 6, a patient who's going for organ procurement, is also understood. It's the ones in between, usually between ASA 2 and 4, that is a little bit grayer. And oftentimes, if a patient is compliant with their health and they're doing all the right things to maintain their health, they're an ASA3. Yes, they have severe systemic disease, but they're able to kind of have the resources and the initiatives to be compliant with care. Patients with severe life systemic disease that's a constant threat to their life, those who don't have access to care or in some way non-compliant, or who've had a recent change in their health, those are the ones that are more likely to have issues. The higher the patient's ASA status is, the more likely they are to have a risk of a perioperative complication. So functional status, how do you ask about the patient's functional status? Do you ask the patient, ask their loved ones, review the chart, observe and examine the patient? I guarantee oftentimes if you ask a patient, are they able to climb 3 flights of stairs? You will, you'll get an answer where you'll say, oh yeah, slowly but surely, no problem. And then you ask about, tell me about the last time that they climbed a flight of stairs. They'll say, oh, I avoid those stairs. It's escalators or the first floor for me. But in their mind, they're able to do it. So how do you ask to really get that real life, real time functional status of the patient? To understand, as I think one of your colleagues stated, their METs. So a combination of all the things that are presented, asking the patient, their loved ones, reviewing the chart, observing and examining the patient. It's interesting. I love to look at my patients, and when they ask to walk to the bathroom, that's really my sign of my way of directly observing their physical stamina. Because oftentimes when I see the patient, they're already in their gown, they're in the stretcher, they're not getting up and down. So anytime that I can directly observe the patient, whether it's they're going to the restroom or they're walking from the stretcher to the operating room bed and helping position themselves, that provides me with a lot of information in addition to being able to review the chart, asking the patient, asking their loved ones. How long the patient can walk without taking a breath? Absolutely. The goal of determining this is that the higher the functional capacity, the more likely they are to recover quickly after their surgery. They're less likely to have perioperative complications overall. A frail patient, in general, frail patient is likely going to have complications, have a longer recovery than a patient who was active on a daily basis. You can intervene to improve their METs prior to surgery. These programs are called preconditioning programs, where they're actively encouraged to take walks, to get more steps in, to watch what they're eating, so that way they're starting or potentially starting at higher METs. Sometimes it depends on the patient and depending on what information you'd like to get, it's sometimes more helpful to ask the patient about their daily activities in general in their home, what they do on a day-to-day basis versus asking about specific activities. And how does asking about these specific activities help you? So oftentimes they'll let you know about the METs or the exercise intensity or tolerance that the patient can have or the patients encounter on a day-to-day basis. So if they're doing light activity, their METs tend to be scored lower, whereas if they're doing vigorous activity, sports, or out taking a jog every day, that's more likely to be higher. So asking what the patients can do versus what they are able or they actually do is something to clarify with your patients, because more often we want to know what they are able to do to assess how they manage the stress of the surgery versus what they think they can do. There's different scales. The Duke Activity Status Index is something that the patients can answer themselves, and based on the number of yeses, you would add that up, and the higher the score, the higher the METs that they're able to complete.